and good morning or good afternoon, depending on what part of the world you're in. This is PerfWeb 106, day 2, and I'm your host, Joe Basha. I'm joined with my esteemed colleague, Dr. Samir Patel, perfusionist extraordinaire, and recently certified by the ABCP. So congratulations on that, Samir. I know you're quite relieved and happy that you no longer have to study.
I am
for the boards.
I'm relieved that I'm not told what, like I was telling you, that I get to pick what I get to read now, you know, which is a lot nicer, you know.
Yes. Those textbooks get rather mundane after a while.
Oh my God, they're the worst.
How many of these facts can I cram into my head for this test?
Facts that I'll probably never use or see. A lot of it, you know what I mean? There's important stuff, but I feel like 70 to 80% of this stuff is just like, when will you ever see that? Like you know,
very rarely, if at all. I would agree with you. But anyway, welcome to the program. Our topic today is going to be on albumin versus crystalloid. What fluid when? And it's a very controversial subject. I think everybody understands that. I fight a lot with various different disciplines at the hospital about what we should be using and when we should be using it.
That's putting it mildly, but yes, I fight a lot.
I use a lot of albumin in my perfusion circuit, since nobody can really dictate that to me, at least where we are, and so in my practice. And so that is very helpful, and I think that it has huge benefit. But it is a very controversial topic, as you'll see by the data. It's very mixed, and we're kind of going to go through all of that and discuss some of these rather confounding differences in what people see and why they see it, and trying to understand all of that. But to contact us, I have to do the housekeeping stuff, if you don't mind. Contact us at perfusioneducation.com. You'll see it pop up there on the screen in just a second. There it is. I see it. And you can send us an email. You can compliment me, criticize me, suggest a topic, request to be a part of our esteemed faculty. Would love to have others who want to join in and maybe share their knowledge and information. I think it would be tremendously helpful. The crawl bar, which you'll see going along the bottom there, you see it now. That crawl bar will be there intermittently throughout the day, and you can use that to look at our YouTube or FaceTime, FaceSpace, or the LinkedIn, or any of the social media platforms that we're streaming to. We stream to all of them, and so whichever one you're on, if you will please like us, subscribe, share. I don't know what other things you can do on it, but it would be very helpful to us. So if you would do that for me, it would be greatly appreciated. That's how we continue to gain in popularity. The MediWeb app, of course, is something that I'm very, very proud of. It is a perfusion calculator, which will give you a lot of information for you to use for your perfusion cases in the morning or the afternoon, whenever you may be doing them. But it also has an ECMO section, a hemodynamics section. It has an IV drug and dose calculator, which is also a standalone app. So this app, the full app, is $2.99. The standalone app is only 99 cents. And if you're let's say you have a nurse as a spouse and you're a perfusionist, you would get the full app, because I think that would be of value to you, but they could get just the IV rate and dose calculator. It's also good for CRNAs, if that's what the situation is. Let your friends know about it. I'm trying to sell 1 million of them so I can retire, and I think that we have sold enough to where I'm in the 900,000s, 999,000s, I think. Or less, baby, before I can retire.
Almost there.
I clearly have a long way to go. But it is a really good app, and it has some super neat features to it. So I would love to see people take a look at it, evaluate it, and for the cost, if you're not happy with it, you know, and you want to just delete it, I'll send you your money back. I mean, really, at the end of the day, I think it's just a really tremendously good value. It could easily sell for not $2.99, but $29.99.
So there's a thing on this app that I actually used this weekend during my ECMO shift. I didn't know it was on there. But I went through the app a lot more now. I plan to use it a lot more now. I have not been using it because of my board exams. I wanted to be able to do the calculations out by hand, because
Sure.
you need to be able to for the board exam.
Sure.
Now that I'm done with the board exams, I find myself using the app a lot because I don't care if I forget some of these equations.
Yes.
I liked particularly, and the one that came in helpful for me was I was doing an ECMO transport to the cath lab.
Oh, so your E-cylinder time, how long
That's
your
the one I used,
Yeah.
Joe. I didn't even know it was there. Then I was like, I had an E-cylinder that was about at 60%, and I was like, okay, how much time is this gonna buy me,
Mhm.
And I put it all in, figured out that it was not gonna be enough time, so I grabbed an extra cylinder just for the road, and I would not have grabbed that extra cylinder, you know what I got an
Absolutely.
extra. I already had one extra. I just grabbed another extra, so I
Sure.
had three,
Yeah, when
plus
you
like 2 and 70%,
Sure.
so
When you transport ECMOs, whether it be by life flight, air,
Mhm.
or you do it by ground, I much prefer ground. You can use we have an app, and usually the ambulance or the air ambulance will have oxygen on board. But if that fails and you have to just live off of your tank, you have
Mhm.
an E-cylinder tank, is what we normally would use
Yep.
for transport. And you would take that and you can put in the amount of pressure you have in the
Yep.
tank and the flow. How much oxygen you're flowing through it, and it will give you a time of how long that tank is going to last. And it's very
Exactly.
useful
It is
if you're
useful.
going down to CT, because there's
Exactly.
nothing more embarrassing than running out of oxygen on the elevator
Mhm.
when you're on your way to CT for a head
Right.
CT or chest CT or whatever it may be.
And I was going for an impella placement, and it's a good thing that I did because they couldn't gain access to the SFA, so it ended up being a very complicated procedure.
Sure, absolutely. So that's our app. And then the last thing is our podcast. No matter what podcast streaming platform you like, Spotify or Podbean or whatever it may be, you can tune in there and listen to us on your drive to work or wherever you may be going. And hopefully, our programs are not just informational and educational, but are also entertaining and fun. And we try to bring some kind of, I guess, normality, if you will, to the programs. That's sort of my methodology for teaching, is to maybe be a little less rigid than I usually can be, and a little more free flowing and have the conversation go back and forth. So we welcome your comments. The guys in the back are monitoring the other platforms, anything but YouTube, and I only monitor YouTube up here. I can't monitor them all. So any questions or concerns or comments, please feel free to say them to me. Okay, let's just jump into this.
Let's do it.
This is a
Excited for
very, very hotly debated topic, which gets argued multiple times on any given day in the cardiac theater, or the cardiac surgery theater, more specifically, or in the critical care unit. And there is an enormous amount, almost so much information that I don't believe really brings anyone to a conclusion. And I want to sort of go over a lot of this stuff. I have to share my clinical experience, and I would like for you to also include this, because you have a lot of clinical experience in this field, and try to make sense out of why do these studies say A and those studies over there say B. So in order for us to kind of delve into this, we have to go over some basic physics, okay, or basic physiology, I think would be most appropriate. Obviously, we have 3 different fluid compartments within our body: intracellular, extracellular, and interstitial. And the extracellular is divided into intravascular and interstitial. Albumin production is synthesized exclusively in the liver. We're going to discuss its turnover rates and the role in maintaining fluid balance of albumin. We're going to talk about the clinical evidence and outcomes, survival data comparing crystalloid versus albumin across a variety of patient populations, and the evidence-based recommendations that are actually published, and they are different from different entities. So that's going to be very important for us to also look at. So we all understand that we are basically all 60% water, by body weight, a little bit less in females. 42 liters is common in a normal average 70-kilo male. Obviously, it's higher than that if you're a 100-kilo male like myself. and it's distributed across the various different compartments that we've already discussed. Intracellular is what it is, and that's 40% of the body weight. 28 liters of your fluid is contained within the intracellular space. And of course, that contains the cytoplasm within the cells. Maintains high potassium, magnesium, phosphate, and protein concentrations. Your extracellular compartment is divided up into two separate places. Your intravascular, which is about 3.5 liters of fluid. The rest of the 2 to 2.5 liters are solids, right? Obviously. And the interstitial space, which is about 10.5 liters. And it's high in sodium, chloride, bicarbonate, and those things. And if you look over here to the right, you see our very typical active transport of sodium and potassium and between the intracellular and extracellular spaces, and how that works, of course, with ATP. And the point I'm trying to make here with that illustration isn't necessarily to discuss active transport. It's to discuss how important fluid balance is for active transport to work. Because when you have sodium and potassium going back and forth, you're maintaining your osmolarity. That osmotic balance is extremely important to both keeping healthy cells, but also maintaining your intravascular fluid balance, because those and your extravascular space communicate with each other. So extravascular communicates with intracellular and intravascular simultaneously, and fluid balance is extremely important. This gives you an idea, we all know this already, of your fluid compartment composition. Intracellular is very, very, very low in sodium. And your extravascular, very high in sodium. Potassium is exactly the opposite of that. Chloride, bicarbonate, and proteins. Your osmotic balance is predicated on a normal value of 286 milliosmoles per liter. And of course, again, you have this active transport that takes place. So you don't want a patient who is severely hypernatremic nor hyponatremic, because it will very adversely affect your active transport system. And very important. Your Starling forces are hydrostatic forces, and these are going to be very important in the following slide to express how our fluid moves within the intravascular and extravascular spaces, because it's extremely important to understand this completely, to completely understand the controversy about albumin administration versus crystalloid administration for fluid resuscitation in various different conditions. So here is, in fact, that slide, and PC is your capillary hydrostatic force. This is your oncotic force. This is your interstitial fluid hydrostatic force. And this is your interstitial oncotic force. So as your blood is going from arterial to venous, you see that your hydrostatic pressure in the arterial is 35, versus in the venous, it is 15, giving you a net movement out at the arterial side or arterial side, precapillary, and back in on your postcapillary side. So your hydrostatic force is what is changed in this circumstance. Your oncotic pressure should remain the same, 25 and 25, on the precapillary or the capillary arterial side and the capillary venous side. The interstitium, there's always going to be some leakage of protein through the capillary membrane into the interstitium. Always. It's a negligible amount, except in severe, let's say, capillary leak syndrome, which is a very big problem. We're going to discuss that quite a bit
Mm-hmm.
in more detail as we move forward with this.
And the negligible
However,
amount is usually cleared by your lymphatics. It's not
correct,
even like
the
a big deal,
negligible amount, but it
right?
still is there. It
Yeah.
would be improper to say it's not there.
Right.
Net out, therefore, is 10 millimeters of mercury force of fluid out into the interstitium, and there's a net 10 in from the interstitium back into the capillary, keeping your fluid balance at essentially zero, right? But if you have an increase in your hydrostatic force in the venous side because of venous insufficiency, heart failure, liver dysfunction, there could be a whole hepatic hypertension, whatever it may be, you will obviously change this number to a lower number, and therefore more is going to leak out than leak in. Conversely, if you do not have a sufficient oncotic force in the capillary as it reaches this point, you won't have sufficient pull, even if the number remains the same, to pull the volume back, because you have to have an oncotic force of between your colloid oncotic pressure, which is redundant. It really should be oncotic pressure because oncotic infers colloid.
Correct.
You have not enough oncotic force to pull the fluid back, and fluid will start to accumulate in the interstitium, and it is a descending spiral where it gets tighter and tighter and tighter. In other words, it gets worse and worse and worse. Once this process starts, no intervention whatsoever, whether it be from the patient's own liver functioning properly and it's your own body trying to correct the problem, or externally by us doing something, it will not fix itself. And this number is important. 25 to 28 millimeters of mercury is your oncotic force. Now, it's very important also to understand that a lot of people do not measure COP, we used to call it, anymore, and albumin is approximately 75 to 80% of that oncotic force contribution. So you can infer by measuring your albumin level whether or not you have an adequate oncotic force within your intravascular space. That's very important. And that's the reason why albumin is used as a surrogate to COP.
Correct.
So edema occurs with increased hydrostatic pressure, and I discussed this. It occurs when you have heart failure, venous insufficiency, renal failure, hepatic congestion, which would mostly be inferior at that point in time, but you still get, your legs will start to swell up. You might develop ascites, that kind of thing. Decreased plasma oncotic pressure when you do not have a high enough protein level. And examples of this would be protein loss in the urine, malnutrition, which would be, of course, proteinuria, but malnutrition. It can also occur due to excessive hemodilution. It can be caused from liver dysfunction, secondary to right heart failure. There's all types of right heart dysfunction. All of these things will contribute. And in fact, just disease states, because the liver does not function well. Synthesis of albumin in the liver is severely compromised in a whole variety of disease processes.
Alcoholic hepatic disease,
absolutely
popular one that causes it.
Absolutely. Increased capillary permeability. Now, this is when you have capillary leak syndrome. And I will say that once you have albumin, they're leaking the albumin out. But
I've heard that a lot.
I've heard that a lot.
So
and or it will just leak out.
Yeah.
But it won't just, it has to do with the size of the protein. Yes. Yes. No.
I think we're back. Yeah, we're back. Yeah, we're back.
We're back?
Yeah, we're back.
Okay. If there was a glitch, everyone, I'm really sorry for that. I don't know what happened, but they just announced to me that there was a technical difficulty, so I apologize for that.
I think it started around the time you started talking about capillary permeability, so
Okay,
you can
so-
probably restart there at number 3.
So with capillary permeability, true capillary leak syndrome is a very serious problem. It's not as common as people want to believe it is, and I've heard people say, clinicians in the critical care unit specifically, no, don't give albumin, it's just going to leak into the tissue. And that's just a red herring as far as I'm concerned because it's extremely rare. But when it does occur, it is serious and it is very severe, and it carries with it a very high mortality. You can also have lymphatic obstruction. Obviously, this can occur. Probably not as much of a problem for us until you start third spacing so much that the lymphatic system actually develops a compartment syndrome because it's a lot more compressible. Veins are much more compressible than arteries.
Correct.
Lymphatics are much more compressible than veins.
Yeah.
So you get enough tissue edema and you will have lymphatic obstruction.
Right.
Albumin synthesis, it is exclusively from hepatocytes, and it represents the body's sole source of circulating albumin. Therefore, the half-life is 19 to 21 days, so I hear quite a bit of people say, no, it's only going to last for 4 to 6 hours. No, it's not going to last just 4 to 6 hours. Let's give it. It's human albumin, and it has a half-life of 19 to 21 days. It's going to be very beneficial. Let's give enough albumin, not just enough to where we raise it from something really low, like 2.1 to 3. No, let's give enough to raise it to 4.5 or 5, and then give more when we need to keep the albumin level elevated. In the absence, I don't want to mean to stress this again, in the absence of known capillary leak syndrome. The production rate is about 150 milligrams per kilogram per day. It can increase by 2.5-fold or more during different stress states or disease processes. But normally on any given day, the liver only produces about 10% of its capacity. So it has a very high capacity to produce albumin, but that is compromised by a lot of various factors. There are limitations, malnutrition, and, if you have a grossly critically ill patient in the ICU, especially those on ECMO, we both know that their nutritional status is horrible. They're deconditioning every single day, especially if it's a VA ECMO versus a VV ECMO, where we might be able to extubate them and get them up and get them moving and sort of get the rest of their bodies working. Liver disease, all of these things will impair production by a significant amount, 25 to 50%. And, of course, inflammatory processes like, hey, are we frozen?
Because my screen is just spinning. And okay. Okay. Cool.
So the cutoff of our hemoconcentrators is 50 kDa. Okay, and that's why albumin doesn't cross it. Well, the cell membrane has a similar size, and albumin doesn't cross it because it's too big to freely go across. You have to have a process which breaks down cell membrane integrity in order for albumin to go in from the intravascular space to the interstitial space. Okay. It's also extremely important for carrying hormones, fatty acids, drugs, ions, and metabolites. It isn't only an oncotic force. Plasma proteins are exceedingly important for a whole variety of things, including, and not limited to what I mentioned, antioxidant, anti-inflammatory, anticoagulants, antiplatelet effect, and modulates capillary permeability and cellular apoptosis in critical illness. So albumin physiologically is understood and known to be extremely important. Here is another page out of a textbook: fluid homeostasis, hemodynamic effects, pathologic states, all of these things. So for fluid homeostasis, it prevents the excess fluid extravasation into the tissues while maintaining adequate circulating blood volume. If you're third spacing and you don't replenish what's being third spaced, you not only have now interstitial edema and poor perfusion to the tissues because at the microcirculatory level it's being compressed, but you're losing your intravascular circulating volume, in which case your cardiac output is going to decrease. So you can easily see where that could be a problem.
People on pump know this too, right?
I'm sorry?
Whenever we're pumping, we see this a lot.
See it
too.
all the time.
All the time. Yeah. Third spacing, loss of volume while pumping.
Exactly. So low albumin levels reduce oncotic pressure, leading to fluid redistribution and potential cardiovascular compromise and critically ill, decreases preload and cardiac output potential, increases interstitial edema and organ dysfunction. Because if you look at a patient, and I'll tell you, this is a quote from, I can't remember who said this, and I feel really bad because I can't give this quote to the appropriate person, but they said, anasarca, when you look at a patient and you see their eyelids look like water balloons, they're blown up, their tongue is hanging out and swollen, their earlobes are dangling, they look like water balloons. They don't look human anymore. They're just completely full of extravascular fluid accumulation. The most I've ever seen that survived was 28 liters, which is a remarkable amount. The interstitium can hide a tremendous amount of fluid, much like the retroperitoneum can hide a lot of blood, right? There's a lot that can be hidden there. But their quote was that anasarca is not simply a visually displeasing finding. Every organ looks the same. So what you see on the outside is what is actually happening on the inside. So think about a heart being that swollen, or a liver being that swollen, or guts being that swollen, or kidneys being that swollen. How can anyone expect them, lungs, how can anyone, the brain, how can anyone expect them to function normally? Okay. Albuminemia, hypoalbuminemia occurs in sepsis, very common, liver disease, malnutrition, critical illness, disrupting normal fluid balance and mechanisms significantly. We talked about that already, so I think we can move forward from there. Here is a slide of, and that was supposed to only come up when I hit the thing. But these are basically the various different salt solutions that exist, what we call normal physiologic fluids. Normal saline is 0.9. It has a sodium level of 154, and it has a, if you see here, compared to plasma, it's hypernatremic, and it has a osmolarity of about 305, 308, I'm sorry, right here. Human plasma's 291, ranges between 285 and 290. So it's hyperosmotic because of the increase in sodium. But it has no potassium, calcium, magnesium, or chloride. Well, it has chloride. I'm sorry, 154 at the same level. Lactated ringers is a little more physiologic, if you will, and its osmolarity is about the same. But it has a little bit of hyponatremia. Not bad, but a little bit. Plasmolite is probably the closest to what would be considered normal, and Normasol R is essentially the same, with just an increase in magnesium and a very slight increase in osmolarity. But all of these fluids, especially if you're using, let's say you have a patient that you want to do ultrafiltration on, you want to do Z-buff. If you use...
now you're about to allude to that sodium.
If you use normal saline, because it has no potassium, you're doing it for hyperkalemia, you are going to end up severely hypernatremic. But you're also going to end up, because if you notice, none of these fluids have NaHCO3. None have sodium bicarb. None. And if you add bicarb to your normal saline, your 154 is now going to be closer to 164, and you will develop severe hypernatremia in order to correct for the lack of bicarb. And that's why I use
the osmolarity too,
and tremendously.
It becomes hyperosmotic.
Exactly. And what happens when you do that? You shrink your cells.
Correct.
Not good for the brain. If you have a closed head injury, great for the brain. If you have a normal intracranial pressure, very bad for the brain. So keep that in mind. But then we get into this, and this is where the controversy today is going to begin. You get into the SAFE study. and I'm just going to distill this down. You have albumin deaths, and you have albumin survivors, and you have saline deaths, and you have saline survivors. Essentially, there's no difference. And they did not view any difference in organ failure, ICU length of stay, mechanical ventilation during the study, that any of this was seen, whether they used saline or whether they used albumin as their fluid resuscitation choice. There was also no mortality benefit over crystalloids in the general ICU population, despite theoretical advantages. And this was by Ronaldo Bellomo. He's down in Australia, and he's brilliant. He's a brilliant guy. I will give him that. But I don't think we're talking about, and this is where this gets very confusing, because people will use this study to argue, we're not talking about the general population. We're talking about cardiac surgery patients. We're talking about ECMO patients. Even if you take just cardiac surgery patients, this cardiac surgery patient and that cardiac surgery patient are not in any way equal.
Right.
And when you try to say it's cardiac surgery, they're both cardiac surgery, that is fundamentally untrue.
Correct. Because hemodynamics will be very different in the two.
Hemodynamics, their basic body condition, their pathologies, their comorbidities, so many things are varied. What the type of operation that's going to be done. Are they a fragile little old lady, or are they you? You know, I would be fine doing an entire procedure with you, though I wouldn't do it, without giving you any albumin. I would not feel that's going to be a problem. Your liver works fine. You don't have any issues. You're basically an otherwise healthy male individual.
Correct.
We wouldn't overly hemodilute you. And that fluid, your liver's going to produce, it's going to uptick. It's going to start working better, and you're going to end up remobilizing that fluid and peeing it out.
Correct.
And that's your normal everyday average cardiac surgery patient.
Correct.
But if you were, rather than that, you were a small 78-year-old fragile female getting a mitral valve replacement who has long-standing cardiac dysfunction secondary to their mitral valve disease, and they have not been moving a whole lot. They don't have an active lifestyle. They have some underlying chronic kidney disease. All of these things involved, I mean, no, that patient is going to react and act and going to recover very, very differently.
Correct.
And optimizing that patient is going to be critically important. And that's the problem with these studies, is they don't subset the various different populations.
Correct.
They take a very broad sample.
Right.
Going over the same thing in this particular study, another study, again, showed no overall benefit. I don't want to spend a whole lot of time looking at this. However, it did see one thing which was very important, and this came out of critical care medicine in 2023. In septic shock, there was a significant mortality reduction with albumin therapy. Very interesting.
Really?
Because
that's capillary permeability.
Well, no, you are at higher risk of capillary leak syndrome in septic shock.
Right.
That is one of the things that can happen. Doesn't always happen.
Sure.
But you are much higher risk of developing that.
But this is in septic shock is when they'll tell you, oh no, there's no point in giving albumin.
Correct. But yet that's the one place that the data that showed that. Showed a significant advantage in mortality.
Wow.
But there was in severe sepsis. Now, we don't tend to deal with septic patients, although our ECMO patients frequently do go septic on us. I think that's not an uncommon thing that we see. But we have what I call septic-like phenomenon. Our syndrome is of issues with these patients, even though they are not technically septic.
Yeah, it's just the inflammatory process.
It is septic-like,
looking like sepsis.
I view SIRS as being a septic mimetic, if you will.
Yeah, that makes sense.
In this particular slide, This is basically, this sucra is nothing more than a fancy way of saying the area under a curve. And with the various different fluids being used, saline, any physiologic fluid, the only advantage in mortality or in ICU length of stay or hospital length of stay was with crystalloid fluids. Albumin is this line here, and you could see that in need for renal replacement therapy, it was the only area where albumin was found to be superior.
Okay.
Now, it trended that direction in AKI, but it was not conclusive. It was not statistically advantageous.
Really? I would have figured AKI would have been.
You would think, but
yeah,
there's the outcome, and this came from intensive care medicine in 2024.
Okay.
In the cardiac surgery evidence, again, it's not just enough for me to say you give it or you don't give it. It's how you give it. I think that there's a factor involved here, which a lot of people don't recognize or don't take into consideration in these studies. But they did a 20% albumin fluid bolus therapy, and they saw no significant reduction in vasopressor duration, and it was the equivalent in clinical outcomes compared to crystalloid. So there are places that will give a 25 grams of albumin. They'll put 25 grams of albumin in their prime.
Right.
Now I put 50 in everybody, but 25 grams of albumin in their prime. But in nowhere in the study are we discussing, well, what was the patient's baseline albumin level?
Correct.
Did they start out hypoalbuminemic or not?
Right.
If they didn't start out hypoalbuminemic and they were not patients who were severely decompensated, I would see that there'd be no difference. But again, I think this is the problem with a lot of these studies. Renal outcomes, there was no reduction in acute kidney injury incidence in this particular study. And we talked about this before, which I found somewhat, I added this, it didn't come from it. But, you can have, when you have renal dysfunction, you get cardiorenal crosstalk and cardiorenal syndrome. But if you look at the how AKI occurs and you get over to this area where you develop CKD, the risk factors from going from acute kidney disease, which evolved out of kidney injury, is your albumin level.
Right.
So again, here is basically just a controversy on one slide, and why I find this so incredibly fascinating. Cardiac surgery outcomes in recent studies. You can see here, there's really no difference. Vasopressor duration, no significant difference. Cumulative fluid balance, well, it was different, but not statistically. But there was a trend favoring albumin. AKI incidence, no significant difference. ICU length of stay had similar outcomes, and hospital mortality had no significant difference. So the data, by the data, says that I shouldn't use albumin. But again, I disagree.
Right.
ECMO patients are a different animal altogether, which I found kind of interesting. In a recent 2024 study, it shows albumin therapy significantly increased hospital survivor in VA ECMO patients, 30, almost 34 versus 24%. Albumin is an independent predictor of survival. And this came out of intensive care medicine again in 2024. Fluid balance optimization. Early albumin significantly reduced crystalloid requirements in the first 6 hours of ECMO patients VA ECMO patients once initiated, and achieved better cumulative fluid balance management. This out of cardiothoracic vascular anesthesia. And in ECPR, there were very specific benefits in that albumin showed significant survival benefit, 29 to just over 29 to just under 19, which is a very significant value when with albumin as an independent predictor. Very important information, but again, it is contradictory, and I think we have to recognize that. Strong evidence supporting albumin. Here's some of that evidence here. Hospital survivor, this is in the ECMO patients that we just discussed. ECPR, major, as an independent indicator. 17-fold reduction in crystalloid requirements within 16 hours, significantly lower cumulative fluid balance, improved hemodynamic stability with early intervention. Okay? So this was strong evidence supporting the use of albumin in these patients. Albumin administration was shown to be an independent predictor for increased survival in VA ECMO patients. We discussed that. That's the same study. I don't think we need to go over that again.
Nope.
Low oncotic pressure and survival. Now, we're going to look at it from a different way. We're going to look at it from what happens when you have a low oncotic pressure versus you're looking at it from do we or don't we use albumin, which one can argue, well, they're one and the same, but that's not really true because there's a lot of people who don't treat the oncotic pressure, and I think that's the issue. You're either giving albumin or not, and you're not subsetting these patients to a known value. This has always been my problem with this controversy, is can we just pick a number that is appropriate within normal range, and I believe high normal versus low normal, or even mid-normal, but I would accept mid-normal. Like I prefer high normal and compare those patients to patients that you allow them to remain chronically hypoalbuminemic. I think they're two completely animals. But you can see across the entire spectrum, it favored albumin. We talked about eCPR and its value. This is essentially saying the exact same thing, so there's probably no reason to belabor the point. The point is there. What is the mechanism of albumin-related complications? Well, we've discussed it. You have a low oncotic pressure. You have fluid being extravasated from the intravascular space to the extravascular space, and you do not have enough force to bring that fluid back because you are hypoalbuminic even if your hydrostatic pressure is still where it should be. It would have to be so much lower, and that's not even feasible or possible. And actually, with venous insufficiency, it's going to increase. So you're going to get a double whammy. The heart, you can start going into heart failure. You have a low oncotic pressure, and on top of that, your hydrostatic pressure at the distal end of the capillary is higher than what it should be. And now you're just going to get a double whammy. You're going to lose even more volume and get even less, if any, back. But that basically creates a essential compartment syndrome within the tissue parenchyma, the parenchyma of the organ. And organ dysfunction is sure to follow. Seen it so many times. You see that sclera just bulging out and weeping, and it is not as I wish I could remember the person who quoted this. It is simply not only a visually displeasing finding. Keep that in mind, please. What you see on the outside is what is happening on the inside.
Happens quick, too.
I think I messed up. I might have messed up. I tapped something I shouldn't have tapped. Yeah, I did. Sorry. I'll go back. Thank you. Sorry about that. This is just a summary of your decision matrix. Albumin advantages, effective volume expansions, longer intravascular retention, not just 4 to 6 hours, oncotic pressure restoration, and potential benefits in septic shock patients with severe hypoalbuminemia. Crystalloid disadvantages, shorter intravascular retention. In fact, you need you need in terms of volume from 25%, I would say you need 15-fold, and the transit time of fluid. In fact, I think I have a slide on this, but when you give somebody a bolus of normal saline, you're only going to get about maybe 30 minutes tops of effect. It's just going to all redistribute at that point in time. So it's only for a very immediate, very short-lived pressure resuscitation. You really, it's not enduring by any stretch. Albumin disadvantage, higher cost. Yes, it is more expensive than crystalloid. I don't think it's nearly as expensive as they argue. Blood product risk, I don't understand that. Potential fluid overload, which is true. I will tell you this, and I've seen this happen before, and I learned from experience. There was a patient who was grossly fluid overloaded, and the albumin level was, I think, 1.2, if I remember correctly, or 1.3. It was so incredibly low. And we were on VV ECMO. And I wanted to correct that albumin, but they were making urine, but not adequately.
Sure. Yeah.
So I argued and argued to get CRRT in place for no other reason than to ultrafiltrate.
Sure, get the volume up.
And they wouldn't do it. So I cut my own hemoconcentrator in. You don't want to, the nephrologist didn't want to do CRRT. I said, fine, I'll just do it myself. And I set it up, and I gave that patient, as I gave them albumin, I had to get fluid off so quickly or I was going to put them into heart failure.
Right.
I was pulling the volume back so quickly, there was no way for the kidneys to be able to produce that much urine in such a short period of time, and I would have put them into complete heart failure from massive fluid overload. So it is something you have to be aware of, that you cannot just correct this unless you are either on VA ECMO or you have an open reservoir, because you have to have some place
for the volume to go.
To put that volume. If you try to stuff it all in the heart, that heart's going to die.
Right.
Crystalloid advantage is the same thing. It says no blood product risk. Albumin is homogenized. No, I'm sorry, it's not homogenized. It's pasteurized. Please forgive me. There's never been an incidence of disease transmission through albumin. Albumin does not have an overdose. There is no upper limit to how much albumin you can actually give a patient. And so this is what's published, but I disagree with it. It doesn't make sense to me. Never in the history of albumin has anyone ever been given a disease, given the process of producing albumin, which again is a pasteurization deal.
Correct.
In surviving sepsis, balanced crystalloids weekly recommended over normal saline. Normal saline seems to be the one. Albumin is not recommended for routine use in sepsis resuscitation. And the International Albumin Guidelines, recent international consensus states the general use of albumin to improve survival in septic patients cannot be recommended. So again, that's a subset of patients. There tend to not be our patients. However, I do believe that our systemic inflammatory response syndrome patients, SIRS, that we frequently see post-bypass, on ECMO, post, contact with tremendous foreign surface areas, and just the inflammatory process of being as sick as they are on pressors and everything else that's going on, I view them as septic-like, but they're not truly septic. Septic infers, obviously, an infection, just to be clear. Evidence-based clinical decision guidelines, when to consider albumin. VA ECMO patients, particularly ECPR, within the first 6 hours shows significant benefit. We're just rehashing this. Septic shock patients with severe hypoalbuminemia, that's less than 2, and I think that's way too low. I think you are severely hypoalbuminemic at 3. And vasopressor dependence requiring volume resuscitation on a continuous basis, you should consider albumin. Large volume paracentesis procedures, greater than 5 liters, to prevent post-paracentesis circulatory dysfunction, and in cirrhotic patients. When to avoid albumin: general ICU patients without specific indications, as no mortality benefits demonstrates over crystalloids in multiple large trials. I agree with that 100%. No specific indication. Hypoalbuminemia is an indication, clearly, to me. It is absolutely essential. That is truly what I believe. The data does not support my position, but that is what I believe. Patients with increased capillary permeability or acute lung injury due to risk of pulmonary edema exacerbation, that's obvious, because you will only make the situation worse. If you have capillary leak syndrome, if albumin is leaking out, you give it, it is going out right with everything else, and you're in a very difficult situation. Routine hypoalbuminemia correction without underlying specific pathophysiology, as may increase mortality risk through volume overload. That is true. I think that even though you may be hypoalbuminemic, if you are not critically ill, you're not a cardiac surgery patient, you're not an ECMO patient, then I think in that subset of population, I would agree with this. In our subset of population, I disagree with this. But this is real and has to always be remembered. Albumin is not benign. There's no overload.
Right.
There's no overdose, but it is not benign. If you're correcting a fluid overload problem that is extravascular and you're going to bring all of that back, I believe it's 18 cc's. I'm pretty sure it is. Each gram of albumin will reclaim 18 mLs of fluid from the interstitial space into the intravascular space. So you can do the math yourselves and figure out how much that would be. I don't think we need to go over that. I don't believe we need to go over that other than to say the Mayo Clinic says no proven morbidity or mortality benefit compared with IV fluid resuscitation in comparison to albumin. I think that's just fair to continue to point that out. Clinical practice, we'll skip that. I think these studies are quite interesting. The SAFE study showed no difference. The Albio study showed no overall benefit, but a 6.3% mortality reduction in septic shock post hoc. SMART trial, balanced crystalloids reduced 30-day mortality versus normal saline. So there's a controversy there. Some say saline, some say balanced crystalloids like plasmolite or lactated ringers or whatever else. So there's even a controversy within which fluid to use. I think we should be using bicarb-based solutions and not acetate-based solutions, because then you at least have an appropriate level of bicarb, and it's been sodium corrected. So I think that's a better fluid to use. But again, it's more expensive, and unfortunately, the reality of medicine is we practice we practice by cost, more so than I think we should. In VA ECMO, albumin increased hospital survivor. That's good. ECPR patients, definite benefit. Early albumin reduces crystalloid requirements in ECMO patients. Cumulative fluid balance at 7 days associated with mortality in ECPR patients. So doing things to reduce that are very important. 20% albumin reduces 90-day mortality in septic shock patients. And balanced crystalloids optimal with 83.1% in the Sucra ranking. So that was over normal saline. Key takeaways, I think that they are obvious. We don't have to go over them specifically. Now, I'm going to real quickly go over this because David Holt is probably one of the smartest guys I know. This dude is really smart. Okay?
He is really smart.
And he wrote this article in 2017 for JECT, who I just got through criticizing. And I'm going to use one of their studies, and this is going to help them with their rankings. Okay, so see, AMSECT, I'm a man of honor. Okay, I want you to understand that. How can I fix this, David? How do I get this out of the way? Cut. There. Okay, thank you.
David Holt, like you've been doing it a long time, so he's like,
Yes, I know. Okay. Oh, man. Joe, I'm a mess, dude. Everybody forgive me. Okay, cut that. All right. I don't know how to turn it back on to the thing. So we're just going to go with it as it is. Can you just blow it up or something? Do whatever. I can't fix it. I don't want to sit here and waste any more time. So his abstract, hemodilution is a common perioperative practice. The deleterious effects of excessive hemodilution and subsequent edema formation have been well documented by numerous authors. COP is a reliable clinical indicator of hemodilution in cardiac surgery. The intent of this study is to determine if a correlation exists between COP and various patient outcome variables. It would also be helpful to know if there is a particular COP value to avoid preventing or limiting patient morbidity. Blood samples from 61 patients, so not necessarily a very high N number, mean age of 70 years old, undergoing CPB, were collected for COP calculation and comparison. So that's basically that part of this. Now, let me see if I can. David, can you help me, please? I'm just really frustrated. It's the read-only file again. No, it doesn't say that. It doesn't give me that option. I'm really sorry. It just doesn't. Home. Okay. Home. Yeah. I told you it doesn't give me that option. Slideshow. Oh. Well, maybe I would listen. Okay. So, yes, thank you, everyone. I'm sorry. I'm not necessarily the most technically advanced individual on this planet. But here we see blood loss, extubation time, ICU length of stay, intraoperative fluids, length of stay at the hospital, perfusion fluid, total fluid, weight gain, and blood given. And if you look over here, you can see for each level of COP, oncotic pressure, and how that affected length of stay. But you can see in every single one of these metrics, other than necessarily perfusion fluid, it is improved by keeping the oncotic pressure higher than letting it be lower.
Right.
Again, it's a very small study population, but it mirrors my own clinical experience. So I don't know who's doing the studies and where they work, but everywhere I've worked, I have seen this. Every one of the cases I do, I see this.
Yeah.
So it's very hard for me to reconcile the difference between my clinical experience and what the data shows. But here you have, in terms of intraoperative fluids, you have far less when you use albumin. Over here in total fluid given, very much less when you keep the COP level at the recommended level. Here in weight gain, very different. Here in blood loss, very different because hemodiluted blood does not clot as well because you're not just hemodiluting the red blood cells, you're hemodiluting everything, including the plasma proteins, which are what helps you clot. Here, look at extubation time compared to albumin. It is much, much longer, much more delayed in terms of ICU length of stay, much shorter with albumin. And he put this formula in here for you to be able to measure COP. If your hospital doesn't, I recommend you simply use albumin level because that's 80 to 85% of your entire COP comes from that. I would use it as a surrogate. But for those of you who want to be, nerdy, there is your formula. In conclusion, the results of this study show statistical significance to support accepting the hypothesis that COP is inversely correlated with the continuous variables: perfusion fluid balance, intraoperative fluid balance, total fluid balance, postoperative weight gain, postoperative blood loss, extubation time, blood product usage, ICU, LOS, and total hospital length of stay. Statistical analysis also suggests that regarding COP, it would be prudent to maintain COP at or above 15. Now remember, normal's 25 to 28, right. So that's even still too low in my opinion. Right. Complementary studies using COP as a clinical parameter could assist clinicians determining the cause and effect relationships. And the reason he says that is because nobody's ever done it. Nobody ever actually measures COP in any of these studies to determine albumin or not giving albumin. Right. And they're not even measuring albumin level, which I just find fascinating to me. Here's my references, and I'm done. Thank you. Sorry for the technical issues. I apologize for that. But with that said, what are your thoughts?
I mean, I'm an albumin lover. I've seen the effects of having a low colloid oncotic pressure. Me being a stroke doctor, I've seen it a lot, obviously.
Yes.
We use a lot of mannitol. We play with COP a lot in the neuro world.
Well, you want your patients to be severe hyperosmotic.
Exactly. So, but in that they give a lot of fluids, and we do drive down the colloid oncotic pressure.
Yes. Which may to some degree reduce the efficacy of your hyperosmolar condition.
Correct. Because we're using mannitol a lot, right? So they're going to pee out volume So we do a lot of volume resuscitation. And we use a lot of clear, obviously. And in that clear, like you said, we're going to dilute out albumin. Eventually, we're going to end up with lower COPs, right? And I myself used to supplement albumin, I wouldn't wait because I know what's going to happen. I know what the next 48 hours are going to encompass. So kind of like I do on pump, I stay ahead of it, on pump, and sure as hell on ECMO. Really want to stay ahead of it. Kind of like you alluded to in all the studies that we saw with regards to ECMO. Plays a much larger role in ECMO. But even on pump, I mean, I go with our standard 25, in the prime, but that's only because you need that 25 because you're about to drop 1 point whatever, depending on how much you wrap or venously take back. You're going to...
Me zero.
You zero, I know, because you don't believe in it, and I don't believe in wrapping either. I've already explained to you why. Mine's the whole... you don't want to cause massive vasoconstriction in the body right before going on pump.
Nobody here wants to hear me rap. Believe me.
You don't
I'm not a good rapper. Okay,
but we still do drop.
Channel my inner Eminem.
So we do still drop at least 1 liter. Of
Tell
clear.
me if you see this.
Yeah,
because you're an ultrafiltration guy. I'm an ultrafiltration guy. I'll go on pump, and I'll have I don't know, a liter, 1,200 in my tank, maybe even 1,400.
Sure.
In my reservoir, my venous reservoir. And I'll start ultrafiltrating. And I'm taking off 500, but I have 1,400 still in my reservoir.
Yeah.
And then I take off another 500.
You still have 1,400.
And I still have 1,400 in my reservoir.
Yeah.
Well, that fluid is coming from somewhere, because not only are you going to ultrafiltrate and increase your red cell volume, red cell mass has a tremendous, tremendous oncotic pull. You're increasing your albumin level, pulling volume back.
Correct.
As you remove it,
Correct.
you continue to increase it.
Right.
And and again, I do feel confident in saying that I think a lot of most perfusionists do such an exceptional job, and their outcomes are great. But I look at my outcomes, and I feel very comfortable that my outcomes are where I want my outcomes to be.
Absolutely, yeah.
And I follow up on these patients post-operatively to see how they did. And I'm very gratified when I go into an ICU the afternoon that we had done the surgery, and I see the patient sitting up in their bed talking to me.
Correct.
It's very gratifying.
Oh, yeah. And
they're not wet. They look good. They're comfortable. They're breathing easy. They're not having any issues.
Normal
they're making
creatinine.
Correct.
It's a good feeling.
It's a very gratifying feeling, yes.
So, yeah, I mean, I agree with 100% about the albumin. Again, because my background, albumin was very important. So I kind of came into perfusion with a love for albumin.
And a bias.
And a bias, correct. So maybe I'm
But how do you reconcile, Samir, I need to ask you, how do you reconcile the reality that the data does not support our opinion?
I reconcile it based on the fact...
Is it bad data?
It's not bad data. You put it very well at the beginning, is the fact that it's too large of a population, of a samples. It needs to be more subsetted, okay? Like, of course, yes, if you look at everybody... That includes people with good kidneys. That includes people with a decent amount of heart output, people with good livers, But that's, like you said, that's not the reality that we are faced with in the profession that we are in. We are going to have portal hypertension patients. We're going to have right heart failure patients. We're going to have a lot of kidney, AKI or CKD patients. So the data... It's hard. I get it. You can't. It's hard to subset a subset. You know what I mean?
Sure.
And then find enough sample size.
Have a big enough N.
Exactly. You can't do it. I get it. I get why they don't do it. You know what I mean? But that also, like you said, you have to understand. Look at the N, and know that it doesn't accurately express what we're going to see. And that's the way I look at all studies, Joe. Like
That's why I like having you on the program. You agree with me so much. I appreciate that.
I'm a realist, and I think I've seen enough, just like you have. Yes, in perfusion, I haven't seen a lot, but Lord have mercy, have I seen AKI? Lord have mercy, have I seen CKD? I've seen diabetes.
But you've been in medicine for a very long time.
Exactly.
Perfusion may be a new field for you, but you have been in medicine for a very long time.
And I've seen enough of heart failure.
Over 10 years.
Over 10 years, correct. So I've seen it all with regards to patients, and what they'll present with the various, detriments that they come to us with. So it's just, I guess it's like an experience game. If you're in it long enough, you've seen enough. And you formulate opinions based on certain things, Albumin, again, my friend, love the stuff. Ultrafiltration, the reason I agree with you, it just makes sense, man. It's really, to me, I don't understand how you can't. I get the AKI, I get the arguments. Now, don't get me wrong. I don't know. And rap, again, I agree with you, but I agree with you differently. You know what I mean? For me, it's the whole why put the body through it when you're about to initiate cardiopulmonary bypass, which already puts the body through enough. Do you really need to do that much?
Well, they have
before going on bypass?
They have to give pressors in order to keep the blood pressure up. And the patient doesn't need pressors.
And you're massively
and if you're having
constricting everything about to go on bypass.
Yeah, and if you're going
that
to be
make any sense to me.
And if you're euvolemic,
right,
then why are you going to give the patient pressors for me to make the patient hypovolemic and not have too low of a blood pressure?
Yeah.
It just doesn't make sense to me. God, I just think it's a common sense thing.
I think it's funny, though, that you alluded to David Holt, but I listened to a lecture of his. And with regards to the initiation of bypass,
he's a PhD in physiology.
Oh, yeah.
The dude is a genius.
So I listened to a lecture of his with regards to the insults of going on cardiopulmonary.
Yes.
And he alludes to a lot of the stuff we just talked about, right now, just a second, with regards to rap. With regards to the massive blood loss that your body will perceive when rapping and this and that, So, I mean, it's funny that you brought him up. And I agree with him with regards to the insults of bypass and anybody that knows him or has listened to any of his lectures, you know what I'm talking about. He goes into real big detail about the insults of bypass and the insults of the initiation of cardiopulmonary bypass. So it's funny that you brought him up.
It's basically controlled shock.
It is controlled shock,
but it is shock.
It is shock, and your body will perceive it that way and will do what it does in response to it.
Absolutely, because we don't turn off all of the receptors.
No, you don't. You don't in the sinus.
They
you
are
going to go in the carotid sinus and turn off your chemo, your baroreceptors, all that. They're all still there.
They are
your kidneys are still going to do what they're going to do.
As far as they're concerned, your aorta has been transected.
Exactly.
And I'm going to try really hard to survive you.
Exactly. So that's my thoughts. Again, I agree with you because you make a little bit of sense.
Tell everybody about your program coming up.
I'm going to be having a program coming up. My program, I'm making it to like what I wish I would have had when I was a medical student. I wish there's a lot of like Khan Academy. There's a lot of information out there that's great. I'm a big supporter of Khan Academy. I like their videos. They got me through a lot of, they're very easy to follow. The only problem that I always had with them, and again, this is not a bad thing. In no way am I playing down what they do because, again, I use them and I love them. But I always found it hard if you were driving a car and you had to listen to anything that these guys are very visual. So I'm trying to make a podcast that you can listen to in audio format. Of course, it will also be in video format, but what's going to make mine different is I'm not going to have any type of visual reference. I will try to describe what you're going to see. I will try to make it to where if you are driving a car, if you are working out, you can understand the topic without having to see a graph.
I think that's going to be really cool.
So
I'm excited about that.
Again, that's my idea.
I'm excited about that.
That's kind of what I'm.
And what's it going to be called?
Paging Dr. Samir.
Very good. So that's what it is. And when's that going to be our first episode?
Let's do it. I want to do it soon, Joe. I just need to be able to get the time. I'm going to start working with Dave. Now that I got this exam out of the way, I have a little bit more time than I had before. Obviously, my priorities were a little different.
If we could maybe get down to maybe one place with ECMO instead of every place with ECMO.
I know. But I can work
we
on
have
it
been
while
busy.
I'm on ECMO
This
nowadays.
is true.
You know
This
what
is
I mean?
true.
So
we
it's
have been
not
busy
that-
as we have been busy as
We've been very busy.
as dog do.
Yeah, and I've been doing like 12-hour shifts on weekends on each day. I've been busy. Like I don't have to tell you. We're both 7
Your
days.
wife's gonna want a new house.
Yeah, she's gonna want a new house. But you know, we're both 7 day per week workers, right? Like I know I am. I very rarely have a day off a week, and I don't know what to do with myself on a day off anyway, so it doesn't matter. So that's the way we are.
Well, as I approach 70, I'm thinking
You
of
need
a lot
to
of
slow
different
down.
things.
I tell you that all the time.
I'm
but
thinking
you don't
about it.
listen to me.
All right. We'll see you. When it was our next program? November 12th.
There
Okay,
you go.
November 12th. What's it on?
What stuff? Here, I'll look it up since.
Well, now we're just going to call it a day.
Okay.
We'll see you on November 12th for our next program. Look online, perfweb.us. You can see what it's about. And thank you all for being with us today. I appreciate all of you, and we look forward to seeing you again very, very, very soon. In the meantime, peace out.
Bye, everybody.